Kanski lecture series, and this is going to be the glaucoma part 13. And in this part, we are going to discuss about the medical treatment of the glaucoma. So, most of the time, the first line of management is the medical treatment. But there are certain challenges that has been associated with the medical treatment, because you have to know that it is a long-term disease and need compliance uh, of the medication. Introduction. It is important to attempt to maximize adherence by providing an explanation of the disease and the rationale for treatment. A discussion of the medication being prescribed, including technique and timing of administration and its potential adverse effect, is also essential. The provision of a written information may be helpful. So you have to discuss that how these kind of medications are very important for the disease to be not progressed. Most glaucoma medications are administered topically, but significant systemic absorption can still occur with resultant systemic adverse effect. Systemic absorption may be minimized by lacrimal occlusion. Following installation, simply closing the eyes for 3 minutes will reduce the systemic absorption by about 50%, and this can be enhanced by applying digital pressure over lacrimal sac. These may also prolong eye drug contact. So what you have to do is basically that glaucoma medication have a local side effects as well as the systemic side effects as well. So for the local side effects, and minimize the systemic side effects, you can ask the patient to, after installation of the dry eye drops, to close their eyes for 3 minutes, or you can just put pressure on the lacrimal sac and then instill a drop. Effect on the periauricular skin may be reduced by blotting overflow from the eyelids with a clean dry tissue immediately after installation. So there are certain side effects that can be associated with the medication on the eyelid skin as well, so that can be minimized if we just put on the tissue and wipe out the excessive flow of medication. The eyelid with a clean, dry tissue immediately. Glaucoma medication should be avoided in pregnancy if possible, with systemic carbonic anhydrase inhibitors perhaps carrying the greatest risk due to its teratogenicity concerns. Prostaglandin derivatives. So, prostaglandin derivatives are basically usually the first line of treatment. Why? Because um, they have a low dose that you could just administered at night and have a low concentration as well. The introduction, the major mode of prostaglandin action is the enhancement of the uveoscleral aqueous outflow. Although increased trabecular outflow facility and other mechanisms have been identified. So, very important of every medication is that you have to understand about the mechanism of action. So basically, the prostaglandins increases the uveoscleral outflow, not the trabeculomaxillary outflow. Their IOP lowering effect is typically greater than alternatives, and a reduction of 27 to 35% from the baseline can be expected. So, after using a prostaglandin drops, you can expect that there is a decrease in the 35% of the IOP from the baseline. A prostaglandin derivative is typically preferred to a beta blocker as the first line of treatment for glaucoma because of the later potential for the systemic side effects. Duration of action may extend for several days, though administration once every day at bedtime is generally recommended. Systemic side effects are few. The most commonly troublesome ocular side effect is conjunctival hyperemia. So one of the advantages is basically that this kind of medications have a low dose administration. It is usually being administered once every day at bedtime. Systemic side effects are few. The most commonly troublesome ocular side effect is conjunctival hyperemia. If one prostaglandin fails to show adequate efficacy, inter-individual receptor variation means that an alternative preparation may be superior in a given patient. Paradoxically, the concomitant use of more than one prostaglandin can rise in IOP. So there are certain agents that have been associated with prostaglandin: latanoprost, travoprost, bimatoprost, and tefloprost. So latanoprost may cause fewer ocular adverse events than other prostaglandins, so it is often the first line. So Latanoprost, so they are different agents. They are basically from the same class. They are prostaglandins, but they have like different efficacy and fewer side effects. So latanoprost have a fewer side effects, and they are used as a first line. Approximately 5 to 10% of the patients show no response, IOP reduction of less than 10% to latanoprost, but may respond to one of the other prostaglandins. Travoprost is similar to latanoprost, but fewer patients tend to be non-responders. Polycord is a novel proprietary preservative introduced by a major pharmaceutical manufacturer in its travoprost formulation that may reduce ocular surface related side adverse effect. So basically, travoprost is usually used in a patient that tends to be um, basically the travoprost has every drops have some kind of preservatives that are not good for the eye. So travoprost basically is using a polycord as a preservative, which is basically less damaging to the ocular surface, but it is similar to latanoprost. Bimatoprost 0.03% has a slightly greater IOP lowering effect than latanoprost, but is more likely to cause conjunctival hyperemia. So it is more, bimatoprost is more effective, but it has more side effects as well. A new 0.01% preparation has a comparable IOP lowering effect to latanoprost with less hyperemia. Preservative free bimatoprost is available. Sustained release intracameral bimatoprost is undergoing clinical evaluation, and preliminary results indicate that IOP control can be achieved in up to 70% of the subject for 6 months with a single injection. So there are certain other kind of investigations that has been going on. Basically, you can also use a intracameral bimatoprost, which is being sustained release, and it can achieve IOP control in 70% of the subject for 6 months with the single injection. Tefloprost is relatively new prostaglandin derivatives and was the first available in preservative-free form. Its IOP lowering efficacy may be slightly less than that of the other prostaglandin agents, but it is well tolerated and seem to cause less disruption of the ocular surface. So what are the side effects of the prostaglandin? So there can be ocular side effects and there can be systemic side effects. So ocular side effects, conjunctival hyperemia is very common. Eyelash lengthening, thickening, hyperpigmentation, and occasionally increase in number. So with the prostaglandins, you can just remember hyperpigmentation. From P is the pigmentation. They're going to be pigmentation in every surface. So the eyelash is going to be lengthened, thickened, and cause hyperpigmentation. Irreversible iris hyperpigmentation occur in up to quarter of a patient after 6 months. The highest incidence is in green brown iridis, less in yellow brown iridis, and less in blue or gray or brown iridis. So there will be the iris hyperpigmentation. Basically, they are more common in green brown, and then it is very less in yellow brown, and it is least in the blue gray. Means that the lowest the iris pigmentation, the lowest the hyperpigmentation of the iris. It is caused by an increase in the number of the pigmented granules within the superficial stroma rather than an increase in the number of melanocytes. So there will be the pigmented granules that have been increased, not a increase in the number of melanocytes. Iris nevi and freckles are not affected. Hyperpigmentation of a periauricular skin is common but reversible. Periauricular atrophy. Pre-operative use of prostaglandin agent may increase the likelihood of the cystoid macular edema following cataract surgery. This is more likely to occur if prostaglandin agents are used in the post-operative period, particularly if there has been a vitreous loss at the time of the surgery. So with the prostaglandin, there can be the cystoid macular edema as well. So they are not used in a case of a post-operative cataract, especially if there is a vitreous loss in that surgery. Anterior uveitis is rare, but prostaglandin should be used in caution in inflamed eye. Promotion of the hepatic keratitis can occur, so prostaglandin should be used in caution in patient with a history of the condition. Systemic side effects include occasional headache, precipitation of migraine, and susceptible individuals, malaise, myalgia, skin rash, and mild upper respiratory tract symptoms. So, in this case, systemic side effect, there can be headache, there can be precipitation of migraine, malaise, myalgia, and upper respiratory tract symptoms. So, these are the side effects. So, A is showing us the lengthening and hyperpigmentation of a lashes with prostaglandin analog. B is showing monoocular prostaglandin analog treatment, darkening of the left iris and the eyelid skin. C is a periauricular atrophy on the left, blepharoconjunctivitis due to topical. D is showing the blepharoconjunctivitis due to topical carbonic anhydrase inhibitor. E is showing allergic conjunctivitis to brimonidine, and F is showing iritis due to brimonidine, showing cardiac perspiration. So, if you just do not remember the side effects, just remember three most important. With the prostaglandin, remember hyperpigmentation. With the carbonic anhydrase inhibitor, remember the blepharokeratoconjunctivitis. With the brimonidine, remember the allergic conjunctivitis. Beta blockers. So beta blockers is usually can be the first or the second line of treatment. Beta blockers reduces IOP by decreasing the aqueous production. So you know that a pKa blocker, beta receptors increases the secretion of the aqueous humor. So beta blocker is used to decrease the secretion of the aqueous humor. Mediated by an effect on the ciliary epithelium, a reduction of a 21 to 27% from the baseline can be expected in most patients. In approximately 10% of the cases, the response decreases with time, tachyphylaxis. So, with the beta blocker, the response is usually decreased with time, sometimes within only few days. There may be limited supplementary effect if or topical beta blocker is prescribed for a patient who is already on a systemic beta blocker. So, if a patient is using a systemic beta blocker, it is a most likely chance that with the topical medication, it is just a little bit of effect. The combination may also increase the risk of a systemic side effect. Beta blocker should not be instilled at bedtime, as this medication may cause a significant drop in blood pressure while the individual is asleep, thus reducing the optic disc perfusion and potentially causing the visual field deterioration. So basically the beta blocker is not instilled at bedtime. Why? Because it will cause a drop in blood pressure and it will cause the optic disc perfusion reduced, and it can cause even the visual field deterioration. The IOP lowering effect is also believed to be less marked during sleep, as nocturnal aqueous production is normally less than half the daytime rate. However, the beta blocker may be preferred under some circumstances, such as monocular treatment, to avoid the cosmetic disadvantage of the asymmetrical periauricular skin darkening or conjunctival hyperemia with prostaglandin. So, in if there is a cosmetic problem to a patient, like he is concerned that their periauricular skin can become darkened with the prostaglandin, then beta blocker can be advised. Beta blockers are also preferred in conditions such as ocular inflammation and cystoid macular edema, or where there is a history of a herpes simplex keratitis. Side effects. Ocular side effects are few but include allergy and punctate keratitis. Granulomatous uveitis has been reported with the metoprolol. So basically it does not have much of the ocular side effects. Basically the systemic side effects are associated with the beta blocker. Though severe problems are rare that have been associated with topical beta blocker use. Bronchospasm. This may be fatal in asthma or other irreversible airway disease. It is critical to exclude a history of asthma before prescribing a beta blocker. So, it is usually fatal in asthma. About 1 in 50 patients without asthma will develop reversible airway disease requiring treatment within 12 months of commencing a topical beta blocker. Cardiovascular. There is a strong suggestion that the cardiovascular mortality is higher in patients taking a topical beta blocker. So, if a patient is having a cardiovascular mortality, cardiovascular problem, then with the beta blocker it is going to be high. Effects include heart block, bradycardia, worsening of heart failure, and hypotension. So with the beta blocker there will be the reduction of all the uh, things, like there will be the bradycardia, there can be the heart block, there can be the worsening of heart failure, and there can be a hypertension. Induction of the later by the beta blocker, by the topical beta blocker, have been reported of as a common cause of a falls in elderly patient. The pulse should be assessed before prescription. A peripheral vasoconstrictive effect means that they should be avoided or used in caution in a patient with peripheral vascular disease, including Raynaud phenomena. So, those who are having a peripheral vascular disease, they can be having a problem with it. Unpleasant but a less severe side effect includes sleep disorders, reduced exercise and tolerance, hallucination, confusion, depression, fatigue, headache, nausea, dizziness, decreased libido, and decreased dyslipidemia. So, with the case of a beta blocker, there can be all of these problems, like there can be confusion, there can be fatigue, there can be headache, nausea, libido. Alopecia is uncommon but is reversible on stopping the beta blocker medication. So alopecia can also occur with the beta blocker. So agents are basically timolol, betoxolol, levobunolol, and cartiolol and metoprolol. So these are all beta blockers. So timolol is available in various forms, including 0.25% and 0.25% solution used twice daily. So basically, the beta blocker I used twice daily BD. It is in the mm, twice daily dosage. So there can be a lesser dosage concentration of 0.25% and more concentration 0.5%. There is no evidence of a clinically significant difference in efficacy between the two solution concentration. Gel forming preparation of 0.1%, 0.25%, and 0.5% are used once daily in the morning. So there can be the gel forming preparation that I used in the morning. Then there is a betoxolol that has a concentration of 0.25% and 0.5% twice daily, has a lower hypotensive effect than timolol. However, optic nerve blood flow may be increased due to calcium channel blocking effect. Betoxolol is a relatively cardioselective beta 1 receptor and is therefore less likely to cause broncho restriction constriction. So, betoxolol is one of the drug that is a cardioselective and it will not cause bronchoconstriction. Levobunolol is a longer acting beta blocker and is used once or twice daily with a similar profile to timolol. Cartiolol twice daily is similar to timolol and also exhibit in intrinsic sympathomimetic activity. It has a more selective action on the eye than on a cardiopulmonary system, so may have a lower systemic side effect incidence. Metoprolol twice daily is similar to timolol but has been linked with the granulomatous anterior uveitis. So, metoprolol is associated with granulomatous anterior uveitis. Alpha 2 agonist. Introduction. Ocular alpha 2 receptor stimulation decreases aqueous synthesis via an effect on the ciliary epithelium and increases uveoscleral outflow. So, alpha 2 agonist. So, basically, you know that beta receptor increases secretion, so that is why you give beta blockers. Whereas alpha 2 agonist decreases secretion, that is why you give them agonist. Means that they increase the activity of the decreased secretion of aqueous humor. So basically it occurs by decreasing aqueous synthesis and also increases UV scleral outflow. There is probably a neuroprotective effect. The medication crosses the blood-brain barrier and should be used with the great caution in young children whom severe CNS depression and hypotension have been reported contraindicated under the age of 2 years. Very important, you must remember, it is a very important part of the MCQs point as well, that brimonidine or any alpha 2 agonist crosses the blood-brain barrier. That is why it is contraindicated in infants and in children under the age of 2 years. They may potentiate vascular insufficiency. They should not be given with oral monoamine oxidase inhibitor antidepressant due to the risk of a hypertensive crisis. So there are certain agents, brimonidine and apraclonidine. They are the alpha 2 agonist. So brimonidine 0.2% twice daily as a single agent generally has a slightly less marked IOP lowering effect than timolol. Allergic conjunctivitis is common. So I told you that always remember that allergic conjunctivitis is a side effect of a brimonidine, whereas blepharoconjunctivitis is a side effect of the carbonic anhydrase inhibitor. But the onset may be delayed up to 18 months after the commencement of the therapy. Granulomatous interior uveitis can occur but is rare. Systemic side effects include xerostomia and fatigue, the latter sometimes being severe. A brimonidine preparation, alpha-GAN, containing a proprietary preservative, purity, have been introduced as an alternative to the more common benzyl leuconium containing forms and may have a greater ocular surface tolerability. So there is a brand name alpha-GAN that have a brimonidine in it, but the preservative used is purite, which has a lower systemic side effect than benzalkonium, that is most commonly used preservative, and causes lesser side effects. Then there is an apraclonidine. 1% or 0.5% is used principally to prevent or treat an acute in the IOP following laser surgery on the anterior segment. The 0.5 concentration is typically used as a temporizing measure over the course of several weeks, such as while the patient is waiting a glaucoma surgery. It is not suitable for long-term use because of the loss of a therapeutic effect over weeks to months and have a high incidence of a topical side effect. So basically, apraclonidine is used when a patient is undergoing a laser therapy, for example, laser iridotomy or any kind of a procedure. So you give the apraclonidine so that the post laser surgery there is a decrease in IOP spike. Next is a topical carbonic anhydrase inhibitor introduction. The carbonic anhydrase inhibitors are chemically related to the sulfonamide antibiotics. They lower the IOP by inhibiting aqueous secretion via topical route. Are used 3 times daily as monotherapy or twice daily as an adjunctive treatment. So basically, beta blockers were giving it twice daily, and prostaglandin was once a daily. Carbonic inhibitors are given 3 times a daily if only it is used singly, but if it is in combined preparation, then it is given as a twice daily. So it carbonic anhydrase inhibitor, basically it has a role in production of the aqueous humor. In general, they are slightly less effective than beta blocker but may have a supplementary neuroprotective effect. They precipitate corneal decompensation in patient with a corneal endothelium dysfunction. So very important, whenever there is a corneal problem, you do not give the topical carbonic anhydrase inhibitor because they precipitate the corneal decompensation. Idiosyncratic bone marrow suppression can occur through cross-reaction is uncommon. Topical and systemic carbonic anhydrase inhibitors are relatively contraindicated in patients allergic to sulfonamide antibiotics. Research suggests that a concomitant treatment with the topical and systemic carbonic anhydrase inhibitor does not usually give an additive effect. Agents are dorzolamide and brinzolamide. The main adverse effects are stinging and a transient bitter taste following administration. Allergic blepharoconjunctivitis may occur but is uncommon. So it has, I told you that the most common side effect, side effects of the carbonic anhydrase inhibitor is a blepharoconjunctivitis. Brinzolamide is similar to torzolamide, but it is less likely to cause stinging and local allergy. It is a suspension and a white residue may be left on the eyelid after the installation if excess is not biodegrade. So these are just 2 types that are be used as a carbonic anhydrase inhibitor in a glaucoma disease. Then there is a myotics. Pilocarpine is the most common myotics that is being used. Myotics are cholinergic agonists that are predominantly used in the treatment of angle closure, though they were formerly a mainstay of treatment of open angle glaucoma. They can be useful in a patient with the pseudophakic or aphakic glaucoma. In angle closure glaucoma, myotic induced contraction of the sphincter pupillae pulls the iris away from the trabecular mixture, opening the angle. So the mechanism of action is that it causes the constriction of the pupil. So when there is a constriction of the pupil, it causes the angle to slightly bit of open up. Myotox also reduces IOP by contraction of the ciliary muscle uh, which increases the facility of the outflow from through the trabecular mesh. Local side effects include miosis, brow ache, myopic shift, and exacerbation of the symptoms of cataract. So the local ocular side effects are that it causes, miosis, it causes brow ache, it can cause myopic shift, and it can cause the symptoms of the cataract to be exacerbated. Visual field effects appear denser and larger. Systemic side effects are rare but include confusion, bradycardia, bronchospasm, gastrointestinal symptoms, and urinary frequency. And the agents are pilocarpine and carbachol. So pilocarpine 0.5%, 1%, 2%, or 4% solution as 4 times daily monotherapy is equal to in efficacy to beta blocker. So these are given 4 times a daily. Pilocarpine gel 4% discontinued in UK in 2012 is 11 is instilled once daily at bedtime so that induced myopia and miosis are predominantly in the confined to sleep. Gel or drops twice daily may be used to prevent angle closure following laser iridotomy in the presence of a substantial non-pupillary block element. So these are sometimes used when there are laser to be done in a case of a angle closure glaucoma. Carbachol is an alternative to pilocarpine. So these are some of the combined preparations, means that different groups have been prepared in a single eye drops and are given to increase the efficacy of the drops. So combined preparation with the similar ocular hypotensive effect to the sum of individual components improve convenience and the patient adherence. They are also more cost effective. Proprietary examples include, so these are going to be all the brand names that contain the different uh, preparations. Like CoSoft has a timolol, and most of them usually have a timolol with an other agent, like it can be um, carbonic anhydrase inhibitor, it can be prostaglandin, it can be alpha 2 agonist. Most of them usually have a timolol in them except Simbrinza. So CoSoft have a timolol and dorzolamide that is being administered twice daily. If there is a timolol and latanoprost, prostaglandin, it is usually given once daily. If um, timolol and pilocarpine twice daily, combinant timolol and brimonidine twice daily, Dovo-Trav timolol and travoprost once daily, Ganfort timolol and bimatoprost once daily. So whenever there is going to be prostaglandin, it is going to become once daily. Then is Tapticon, then it is timolol and tefloprost once daily, Azerga, timolol and bronzolamide twice daily. Simbrinza, Bramanidine and bronzolamide, a new combination, the only combination that does not contain the beta blocker timolol, administered twice daily. So there are certain new topical medications that have been introduced and are in the research processes. They include latanoprostene bunod 0.024%, is a which brand name is Y Zulta, is a new FDA approved topical medication that reduces IOP significantly. It has a dual mechanism of action. The latanoprost component increases the outflow through the uveoscleral route, and the butanediol mononitrate component undergoes further metabolism in anterior chamber to produce the nitric oxide, which has effect on the trabecular meshwork, leading to the enhanced aqueous outflow. It is used once daily and reduces the IOP more frequently than the latanoprost alone. It has similar side effects to the other prostaglandins. So basically, latanoprostene bunod has a combination drop. It contains the latanoprost and it contains the butanediol mononitrate. So latanoprost basically have a same effect like prostaglandin. It increases the uveoscleral outflow, whereas butanediol basically in interior chamber it metabolize and give production of the nitric oxide, which basically acts on the trabecular meshwork and increases the outflow. So these are more effective in lowering IOP. Next is the Rho kinase inhibitors, which are ROC, are a novel class of a topical medication that increases the outflow of the aqueous through trabecular meshwork. The drops are instilled once daily and are effective in combination with the latanoprost, roclatan. Rho kinase inhibitor are slightly more effective than latanoprost in reducing the IOP. So basically, it also increases the outflow through trabecular meshwork, and it can be used with the latanoprost, and with if it is used with the latanoprost, it is known as rocklatan. Then there is a systemic carbonic anhydrase inhibitors, which are usually given for the systemically, but they have an ocular effect as well in reducing the IOP. So, administered carbonic anhydrase inhibitors are generally used for short-term treatment, particularly in patients with acute glaucoma. Because of their systemic side effect, long-term use is reserved for the patient who at high risk of visual loss. Sulfonamide sulfa-allergy is a relative contraindication. Agents is acetazolamide, dichlorphenamide, methazolamide. So these are the agents. Acetazolamide is a variable available at 250 milligram tablets, 250 to 100 milligram daily in a divided dose. Sustained release 250 milligram capsule, 250 to 500 milligram daily, and 500 milligram powder vial for injection. Single dose typically used in acute angle closure glaucoma. So basically, AZM or acetazolamide are given in a have a concentration of 100,000 milligram to be given. Usually, the dose is 250 gram, which give in a QID or 4 times a daily, the oral medication. So it can also be given via IV, and there is a 500 milligram powder vial for injection. Next is the dichlorphenamide, that is a 50 milligram. Tablets are given, and they are usually given 2 or 3 times daily. Methazolamide 50 milligram tablet, 50 to 100 milligram 2 or 3 times daily. This has a longer duration of action than acetazolamide, but less widely available. Side effects: ocular side effects, and they're going to be systemic side effects. So ocular side effects are the choroidal effusion, particularly after cataract surgery, angle closure may result. So ocular side effects are the choroidal effusion. Systemic side effects are the paresthesia, pins and needle sensation in extremities. There can be the hypokalemia, reduced blood potential level. There can be malaise, lower mood, gastrointestinal symptoms, renal stone, Stevens-Johnson syndrome, very rare. Dose-related bone marrow suppression, idiosyncratic aplastic anemia, exceptionally rare but with 50% mortality. Osmotic agents. So osmotic agents, so basically what is do they basically are given in the blood that have a like a higher concentrations. And what is it will just take up all the water content from the other tissue organs into the um, blood. So what it happen is that it will increase the pressure on the heart, and it will increase the blood volume, and it will increase the pressure in the heart and the kidney. So they are usually given very cautiously in patient with such kind of diseases. Osmotic agent lower IOP by creating an osmotic gradient, so the water is drawn out from the vitreous into the blood. They are employed when a short-term reduction in IOP is required that cannot be achieved by other means, such as a resistant acute angle closure glaucoma, or when the IOP is very high prior to intraocular surgery. They are of limited value in inflammatory glaucoma, in which the integrity of the blood-aqueous barrier is compromised. Side effects include cardiovascular overload as a result of increased extracellular volume, caution in a patient with a cardiac or renal disease, urinary retention, especially elderly, headache, backache, nausea, and confusion. So there can be agents mannitol, glycerol, isosorbide. Mannitol is given intravenously 1 gram per kg body weight or 5 ml per kg body weight of a 20% solution in water over 30 to 60 minutes with a peak action within 30 minutes. Glycerol is an oral agent 1 gram per kg body weight or a 2 ml per kg body weight of a 50% solution with a sweet and sickly taste, and can be given in lemon, not orange juice, to avoid nausea. Peak action occur within 1 hour. Glycerol is metabolized to glucose, and careful monitoring with insulin cover may be required if administered to a well-controlled only diabetic patients. Isosorbide is a metabolically inert oral agent with a minty taste. Using the same dose as glycerol, it may be safer for diabetic patients. So these are that's it for the glaucoma part 13. See you in the next lecture series.